Good morning, clinical problem solvers. Just want to welcome everybody to a special Tuesday edition of VMR. Unfortunately, we don't have POCUS VMR this week. We weren't able, or I wasn't able to get somebody to present a case at short notice, but we'll convene for a regular VMR. Before we get underway, I just want to highlight if anybody has a case, and it doesn't have to be completed, and you can sort of shoot from the hip and present a few aliquots. Please let us know in the chat or mute your mic and tell us if you have a case. But otherwise, how's everybody doing? I see David. David's here. Amir, how are you? Rafa, what you been up to?
Oh, it's the time of the year that the med season's coming. So I've been joining this open house internal medicine residency. It's really incredible. I was talking with Ravi. You can get a sense of the program, so I highly recommend it. People join this type of sessions. And yeah, what about you, Yasmin? What have you been up to?
Well, I'm still preparing for my step one. I haven't received my token yet, so I'm kind of nervous because I wanted to present it like in this month. My token is arriving. So I'm preparing. I feel good. And yeah, by the way, any applicant for internal medicine, I made a calendar. I have been updating it for all the open house fairs. Thank you, Dania. I hope so.
Yasmin, I saw that. That is so great. That document that you made. So that's very helpful for everybody to keep track of all the open houses. Awesome. Thanks for doing that. How are you, Ariel?
Hi, everybody. I've been back to vet school learning about kidneys for the past 3 weeks. It's going to be 46 degrees Celsius in Davis today, so it's nice to start the day refreshing like this.
Awesome. Kidneys are phenomenal. And you've probably got a hint of kidney and all of its different issues from CPS VMR. So excited to see what you learn. I guess if anything, pre-renal, intrarenal, post-renal is a great starting point. All right, anybody have a case? Okay, Rafa, you have a case. Awesome. So we can start the whiteboard and get going.
Can you see it?
Yes, thanks.
Oh, perfect.
Okay,
I'll also ask the crowd to give their input in the chat, and if you're able to unmute your mic, please share your thoughts. We'll do a crowdsourced VMR today. Go ahead, Rafa.
Okay, so Yasmin, please let me know if there is something that is missing so I can repeat to you again. Okay, so this is a 74-year-old male presenting with fatigue, weight loss, and joint pain. I'm gonna leave it at that.
Awesome. So I'll wait to see if anybody has any ideas. So 70-year-old male with fatigue, weight loss, and joint pain. Joint pain, wrist pain, or joint pain?
Joint pain.
Okay. Okay, we have a great starting point here. David, are you able to unmute your mic and share? If it's okay, if not, I'll read off your comments.
Okay. I just posted that my first thought is as in other cases, if this is this joint pain is arthralgias or is arthritis. Because, well, we have a 74-year-old man with inflammation and trying to sort out if this joint pain is and not a specific joint pain or something that will point out to one direction. The first thing I want to know is if this is arthritis.
Absolutely, absolutely. I really like that you're highlighting the joint pain. What here can we really dwell on or concentrate on? You have fatigue, you have weight loss, but then what really stands out, what could be the center of gravity here is the joint pain. Then you want to know, like you mentioned, the joint pain, is it systemic? Is it one joint? Is it oligoarthritis, 2 to 4 joints, or is it polyarthritis? So we'll probably need a few more aliquots, or in the next aliquot, Rafa will give us more information. I think Dani had mentioned something about the fatigue and weight loss. Dani, are you able to unmute your mic and share your thoughts? Those are some great comments that you have in the chat.
Yeah, of course. Can you hear me?
Yes.
All right. So whenever I see fatigue, weight loss, and I think that's thanks to RLR and all the times they've mentioned that whenever we see fatigue and weight loss, we need to see if this is because of decreased oral intake, decreased caloric intake, or because of any causes that may have led to excessive energy expenditure, caloric expenditure. By that, I mean whether this is, in some cases, it may be intentional weight loss or systemic inflammation, or maybe a malignancy, any infection that may have led to excessive energy expenditure. I guess what I'm trying to say is more heat loss and caloric loss, I guess. And that imbalance would have caused that weight loss and fatigue. So because this patient is a 74-year-old male, since the age factor is leading me towards, thinking more towards any inflammatory cause, any infectious cause, that can be either not, I don't know if it's autoimmune, because this patient is, again, not that, this is an elderly patient. So maybe an infectious cause or malignancy, not sure, especially if there's joint pain, because if I correlate fatigue, weight loss with joint pain, that can be systemic manifestations of any infections, I guess. I would like to would like to know more about the joint pain, like David mentioned as well. So not just the location of the joint pain, but also the onset of the symptom, whether it has been present for a very long time, or is it something that has occurred fairly recently?
Great analysis there. I really like that. Yeah, Dania, that was great. Especially highlighting the epidemiology. So in a 74-year-old male, probably less likely autoimmune, but we're really thinking about what could be unfolding here is an inflammatory condition or an infectious condition. So I would prioritize that at this point, but still we're lacking a lot of other information that Rafa will give us in the next aliquot. And just one more comment about what Yasmin mentioned. I really love this thought about, is it the joint or is it around the joint? What are you thinking, Yasmin?
First of all, I will think if it's in the joint, if it's an articular issue, and then we will go to see if it's an acute or chronic, or is it periarticular? Because sometimes patients feel, oh, my elbow or my knee is, I have pain in my knee, but periarticular pain could tell us if it's tendonitis, if it's tenosynovitis, enthesitis, myositis, fasciitis, or even cellulitis. It depends. And I will also look for these clinical signs and symptoms of inflammation of the synovitis. I don't know how to say that in English, I'm so sorry. Which would be if the joint or the area where the patient reports this pain has edema, tenderness, effusion, if there is this morning stiffness, like more than 30 minutes, it's always there. Like the patient always said, like, in the morning, I have to wait like for a while when I wake up until I can use the circulation. If there is pain and stiffness that worsens with activity or with inactivity, I'm sorry, the activity normally makes it better. And of motion, I will look for that and define if it's exactly in the joint or if it's around all the structures that are around it.
Okay. Some great thoughts on the inflammation in the joint, and you really expanded the possibilities there. So I couldn't have explained it better. So I think we'll probably need to go back to that once we get more aliquots and more information from Rafa. Rafa, the next aliquot, please.
Sure, great thoughts, everyone. So patient notes non-fleeting pains involving bilateral shoulders and hips with gradual progressive involvement of the proximal lower limbs and calves over the last 18 months.
Are we stopping here?
No. I'm
Okay.
giving time for the scribe. Symptoms are worse in the morning, like 1-2 hours, and slowly improve throughout the day. This patient also reports fatigue over the same time period and an intentional weight loss over 8 months. On the review of symptoms, this patient denies fevers, chills, chest pain, headache, and jaw claudication. This patient also denies joint swellings, muscle wasting, limb claudication, and digital ischemia. I'm going to give you the past medical history as well. This patient has a history of normocytic anemia, and he denies prescribed or over-the-counter medications or herbal supplements. There is no history of tobacco, alcohol, or illicit drug use. And this patient, he worked as a subcontractor for a residential home building company. And there is no pertinent family history. And that's the end of the aliquot.
Great, Rafa. I'll mute my mic to see if there's any thoughts before we get going. Oh, Amir has a great thought there. Amir, are you able to mute your mic and share your thoughts?
Yeah. So I was thinking about the proximal distribution of his symptoms, So that leans more towards polymyositis, where it's more trouble getting out of chairs or going up the stairs or lifting their hands above their head. So these proximal muscle girdles are affected. But as many have pointed out in the chat, it could be polymyalgia rheumatica. I'm not quite sure how to be very exact with diagnosing that one. But I just want to ask Rafa, you said his work history is what exactly?
Past medical history.
His work, I mean, what did he do for
he does for a living. Okay. He's a subcontractor for a residential home building company.
So, yeah, if he was exposed to asbestos, I mean, he's quite old, so maybe he has some history of asbestos exposure that could be a risk factor for lung cancer, which in turn could be triggering some of these autoimmune conditions like polymyositis. Yeah, that's all I have.
Yeah, I really love that thought. It was interesting. Rafa had also mentioned, was it no jaw claudication? Does that necessarily rule out, you had mentioned GCA, PMR, could that still be in play here? could possibly, not everybody will manifest with all the associated signs and symptoms, but yeah, here also mentions PMR with GCA. And we are in the right epidemiological age range. So something to highlight up on in our list of differential diagnosis. Arlo also mentions polymyalgia rheumatica. I'm also interested to see if there are skin manifestations. Dermatomyositis also has associations with proximal muscle weakness. But other thoughts, we want to cast a wide net and not just anchor on one possible diagnosis, but we could also think about necrotizing autoimmune myositis and inclusion body myositis. But they have different sort of presentations, but they also have a symmetrical proximal pattern. So things that we need to also think about. And then also if there's any, if we have in the med statin associated myositis, but there's no statins that the patient's taking, right, Rafa? Okay. So we can probably discard that possible diagnosis at this point. But that's something that we do see. And there are two types that we can have. We can have an autoimmune variant or direct toxicity from the statin agent. But at this point, we're not going to dwell on that too much. That's not possibly something to consider since the patient's not taking any statin agents. David, you have a great thought about IBM. We can sort of go through the illness script for IBM and see if it has any relevance on this case.
Yeah. Just want to point out that IBM, I think, as I can remember, that it tends to be more asymmetric and tends to involve more distal parts than polymyositis and dermatomyositis. Also tends to appear in more advanced age than the others. And I think for these men with 74-year-old, it would be a bit odd to present like a first polymyositis or dermatomyositis, but maybe IBM fits better.
Absolutely. Some great details about IBM there that usually it's chronic and it takes quite a while to manifest. And you're right, it does have a pattern of proximal plus distal, which doesn't fit this patient, where hearing from Rafa, this patient has more proximal muscle involvement. So I think we can probably move that diagnosis to the side and then entertain all the other ones that we thought about. Any thoughts about NAM? When would NAM come into consideration for something like this? Oh, necrotizing autoimmune myositis. So what I remember from that would be there's usually an offending agent that's associated with necrotizing autoimmune myositis. So there's a very high CPK that's involved with that as well, and also autoimmune antibodies that are also associated with that, sort of similar to statin-induced myositis. So I would expect you can have an acute, subacute presentation in that condition. But there is mostly proximal involvement. But again, there's no list of meds, so I really don't think there's an inciting agent that's involved with this disease. So that's something also I would kind of take out of contention for a possible contributor to this. So we're still thinking about dermatomyositis, polymyositis, more polymyositis at this point, and GCA with polymyalgia rheumatica. Any other thoughts? Oh, Yasmin, could you expand on your comment there? I'm kind of interested what you were alluding to.
Of course, it's a good thought. But I will think this patient, if this was the case, he would be, let's call it, complaining of issues like I cannot get up, I cannot climb stairs, this weakness is such that I cannot stand up from a chair, especially if he has been, 18 months. I'm so sorry, I wrote before. Especially if he has been having these issues for 18 months, I would expect a higher muscle death rate. Although it's true that in NAMS, the inflammation is less than in polymyositis, the issues in the muscular function would be more will be remarkable, especially with this time of development.
Rafa, can we go on with the next Scala-Quad, please?
Yeah, sure. I'm gonna give you the physical exam for this patient. Vital signs 37.2, temperature 37.2 Celsius. Respiratory rate 17, and his blood pressure is 130/80, and his heart rate is 65. I saw that the temperature is 37.2. Regarding his neck, there is no lymphadenopathy, no thyromegaly. His HEENT exam is completely normal, no temporal muscle tenderness. Cardiovascular exam, regular rate rhythm, S1, S2 normal, completely normal. Lungs also normal. Abdomen unremarkable. Skin, there are no skin lesions. Near exam, coronary is intact. Normal gait. Muscle strength is preserved in all extremities. His range of motion is intact. There is no evidence of active peripheral joint synovitis or effusions. There is no enthesitis, non-tender SI joints. Muscles were non-tender and no digital ischemia. So basically, I guess, a very unremarkable physical exam. But to give you something to work on, I'm gonna give you the initial lab work. His hemoglobin was 120, I guess this a gram per liter, so I guess it would be 12. MCV 86, normal. And his white blood count is 9.9, and it's neutrophilic predominant. His platelets are 313. Sodium 144. Potassium 4.7, chloride 104, bicarbonate 29. His BUN is 9.8, and his creatinine is 1.1. I'm gonna give you also a little more of labs. His total protein was 6.2. No, I'm sorry, 62, which is normal. And his albumin is 32, which is a little bit lower. His ALP was 73. And his bilirubin was 13. Gamma GT 16, which is normal. His bilirubin is 13 U mol per liter, which is normal in this unit. So I guess it would be like 1.3 is bilirubin. AST 21 and ALT 19. And that's the end of the initial labs.
Oh, great! Great, Rafa. Thanks for the detailed information. Now it's really interesting. There's quite a bit of information which moves the needle forward in regards to some of the conditions that we were entertaining. I'm gonna ask David. You have a great thought there. I'm right along with you in this possibility. But tell me why you're thinking more PMR now than some of the other conditions that we were thinking about.
Yes, the exam is not very positive for weakness. So, well, the exam it seems to be normal now, but the symptoms could be only elicited by movement, so by action. So maybe I think the predominance here is the pain, and that seems to be like, yeah, kind of periarthritis, or I don't know if the physical exam is good enough for like saying that confidently that one can have periarthritis and not other arthritis or something similar. But yeah, I think the pain is what is predominant here, and that points more to VMR than to polymyositis, dermatomyositis, IBM, and that things. Also, is I think, well, in the labs, it takes my attention that platelets are not well elevated for thinking in a subacute inflammation that I would expect more elevated. Like, well, would want to see also an CRP or ESR if that was elevated and pointing more to subacute inflammation.
Great thoughts there, David. I absolutely agree with you on a lot of points there. That what Yasmin had gone through, especially with the joint inflammation that Rafa's mentioned, there's no synovitis, there's no actually joint involvement there. The pain is more surrounding it's more of a muscular etiology. But that what Yasmin had mentioned, we can now bring in and consider all the possible causes. So joint could be just a constitutional symptom, and it's not primarily the joint where we're going to focus all of our attention on. So we're going to put all of our cognitive energy into, again, thinking about proximal muscle weakness and all of the different causes. Well, what's a challenge here is, yes, everybody's asking for the ESR, but let's step back and then move towards obtaining labs that will help us refine and get to our diagnosis. So going through all the different causes of proximal muscle weakness, definitely the polymyositis, dermatomyositis, but there's no skin involvement. So polymyositis still is in contention here. But with this patient and the proximal muscle weakness, there's what was I going to say? There was fever, I think a low-grade fever. There's no muscle weakness in the physical exam that Rafa had mentioned. So this does fit polymyalgia rheumatica, and then to help further make that diagnosis, the ESR will be helpful. Somebody had mentioned about the AST-ALT numbers not really being high. If the AST was elevated, could that indicate muscle involvement, muscle breakdown, muscle injury? So AST can come from a lot of different issues. So with rhabdo, you can get elevated AST. With hemolysis, you can get elevated AST. Anything else here that could help us to move closer to that diagnosis? I really don't see anything here, but again, the physical exam does help. Patient has normal gait, no skin lesions, no enthesitis, so we can immediately strike off no spine, no back involvement. So spondyloarthritis, spondyloarthropathies are a large group of disorders which we can immediately take out of contention. No tenderness in joints, no erythema, no skin involvement, intact range of motion. So no limitation of motion also does help in trying to refine and define this diagnosis. And is the albumin, oh, somebody had mentioned albumin is 82 here. I think that might be a mistake. What was the albumin, Rafa?
It's 32. It's a little bit
32.
lower.
Okay. And I think Hira had a thought of TSH. So we didn't really journey into the domain of endocrinopathies, but hypothyroidism could be a possible cause of generalized weaknesses in this patient. And then Joseph mentions PMR won't involve proximal lower limbs. Any thoughts regarding that? And then Yasmin mentions about paraneoplastic syndrome. Would you like to expand on that, Yasmin? That's also a great thought, that there could be something else hiding behind there
Yes,
that could
like,
be triggering this.
Of course, there are some literature reports that paraneoplastic syndromes can present like PMR, and actually wouldn't. There are like many cases reported that do not find a high ESR level, contrary to what one would expect, because it's inflammation, right? And that the periarticular inflammation that the paraneoplastic syndrome causes can mimic PMR and polymyositis in some cases. In this case, I will go with that maybe. And it is due to the increase of cytokine production, and that's why there is a correlation. But I would definitely look for maybe esophageal carcinomas. I will look for any GI tract carcinoma, the upper GI tract carcinomas, because I have read about how these cancers can create a paraneoplastic syndrome mimicking PMR or polymyositis.
Yeah, absolutely. Great thoughts there. That helps or makes me more confident in the group thought that this could be one of those two diagnoses. Yeah, what's interesting here, I think Danny had mentioned PMR can affect the hip joints. Yes. So the hip and the shoulder joints are usually involved, but you can always have atypical cases that may not follow the trend here. And the pain usually is worse in the morning. And in this patient, we do see that the pain is worse in the morning. Let me just look back at so the pain is worse and improves towards or throughout the day. So that does align with thoughts of PMR possible as a cause. And then David, David's actually filled in the chat with some material from up to date. David, could you go through that and help us to come to a final diagnosis?
Well, I've just looked how common is in PMR to have distal symptoms, and well, up to date states that it could be in up to half patients could have distal symptoms. It's one half, most commonly in wrist and metacarpal phalangeal joints, but it's not such common in feet and ankles. And well, I think just to point out that this involvement of proximal lower limbs in this case, I think it wouldn't dissuade us from PMR, but could be also present.
Yeah, absolutely. The hands and wrists can be involved, although, like you mentioned, 10 to 15%, so which may not be manifested with all different presentations. Rafa, is there any more aliquots before the final DX?
Yes, there some additional lab workup. I just wanted to know if you guys are interested in knowing about the serum cortisol, and if yes, why?
If you have them, why not?
No, I do have it. I'm just curious if you have any thoughts why the person who prepared this case was interested in the serum cortisol.
Dania mentions, well, now we do. So yeah, if with serum cortisol, with if we're thinking adrenal insufficiency, we don't see, it can manifest with nausea, vomiting, fatigue, and any number of this what you call protein manifestations that you can get with it. But it could, as I mentioned before, we didn't really go down the rabbit hole of endocrinopathies. So the ones that do stick out in my mind, definitely hypothyroidism is one, and then the other is adrenal insufficiency, which can manifest with a whole number of different conditions. So I definitely would like that, as Danny had mentioned, TSH at least, and the cortisol level. But what kind of counts against if we had adrenal insufficiency? So serum sodium is normal here. You would expect at least hyponatremia in this case, but we're not seeing that here. What about Cushing's disease? Yes, Cushing's disease. On the flip side, Cushing's disease, that could also manifest with weakness. But again, we would look for other manifestations such as the body habitus, also with laboratory abnormalities. Any input from the crowd in regards to Cushing's disease? That's a great thought here. So hyperkalemia can also manifest with adrenal insufficiency.
I saw that Dania raised her hand.
Oh, okay. Dania, and then Yasmin also has some input. Go ahead, Dania.
All right, so Rafa mentioned something about Cushing's disease, and although with Cushing's, we would like to see certain manifestations of there are classic manifestations of Cushing's, which is, that faces, maybe weight gain, maybe buffalo hump, some stria. But I do remember, if I relate to one of the cases that I saw in a patient who had been taking exogenous corticosteroids because of their chronic osteoarthritis for I think maybe it was an osteoarthritis, but I don't exactly remember why, but they had been taking corticosteroids for a very long time. This was an elderly lady. She was quite frail. Her skin was quite, looked very thinned out. She was not obese at all. And we saw very similar symptoms, which were quite vague: fatigue, weight loss, joint pains, and high cortisol levels. So yes, I do think, maybe not exactly Cushing's, but due to exogenous steroid, we can have these manifestations.
Absolutely brilliant. That's a great breakthrough or breakdown of Cushing's disease, or a number of signs and symptoms that I would look for, that you nicely described, which we're not seeing here. Yasmin, you had a few thoughts as well?
I'm not sure if this could have any, if this patient would have any hypercortisolism issue. Although he has weight loss, although he has muscle aches, also he has fatigue, lethargy, he also has he doesn't look like he has orthostatic hypotension. I think that if we had any kind of hypercortisolism going on here, we will find hyponatremia, we will find hypoglycemia, especially because this has been 8 months. And any other cause of hypocortisolism would be primary, secondary, or tertiary, adrenal insufficiency. And the other one that would click, because secondary and tertiary tertiary one is due to discontinuation of exogenous glucocorticoids. I will think maybe it could be a primary adrenal insufficiency due to an infiltration of the adrenal glands. It could be, tumors. It doesn't click a lot with amyloidosis, or maybe a secondary adrenal insufficiency, maybe for, stress or any infection. But again, he doesn't have any other thing that could orient us to say, well, this patient had an infection and then that fried his adrenals. So we have to look for that, I think.
Yeah, that's a great thought, Yasmin. I'm right there with you in this clinical conundrum here of if we have to explore hypercortisolism or hypoadrenal insufficiency or Cushing's here. But yeah, we're missing a lot of the usual hallmarks of Cushing's disease, with the buffalo hump and the moon faces and stria and so on. But you can have, as we all know from VMR, we've had some very atypical presentations, so it could happen. Just dissecting the labs too, as people mentioned, the hyponatremia, hyperkalemia, NAGMA. You can also get a NAGMA from adrenal. On the adrenal insufficiency, you get these abnormal lab markers as well. So what's interesting with Cushing's, though, you can get muscle. You do get weakness, but you also get loss of muscle with breakdown of muscle. So you get very thin extremities in Cushing's disease, which weren't highlighted here. But somebody you mentioned weight gain as a possibility here, which we're not also seeing. But I guess Rafa will give us the serum cortisol, give us a TSH as well, and we'll munch on them and see what we can find.
Incredible discussion, everyone. So the ESR was elevated to 45. The CRP was also elevated to 35. And his ANA, ANCA, and CPK were all negative. And the serum cortisol was actually normal, 343. I just wanted to check what was the input from the crowd. Oh, and then I will with the final diagnosis, the next cell.
Oh, that was a Rafa moment there. But it's great to dissect that and just go through how you could manifest with adrenal insufficiency and hypercortisolism. So thank you for that exercise. Let's see, any thoughts now? The ESR is elevated. Absolutely, David. Prioritizing PMR and the CPK being normal. Remember, we went through CPK could be elevated with polymyositis, NAM, IBM, and so on. But in this case, with PMR, the CPK will be normal. So yeah, it very much mimics the illness script of PMR. So any other thoughts? Oh, Dania, you had a thought there. You have your hand raised.
No, I think I just forgot to lower it the last time I raised it. Sorry.
Oh, no worries there. I was like, oh, great.
But I did point out that the cortisol is probably a red herring, and it was.
Awesome. I was like, it was great to sort of think about that. I think it was a great exercise. Like, wait a minute, let's think about that. Could it fit? And it really didn't fit, even though we ran through the illness script of Cushing's disease and also adrenal insufficiency. We couldn't find a way to really hang the diagnosis on that. So I kind of applaud the crowd that nobody really fooled or fell into Rafa's trap right there. So good job, everybody. So Rafa, the final DX, please.
Okay, so based on the clinical history and exam, the patient was offered a temporary biopsy to confirm a histological diagnosis of large vessel giant cell arteritis, which he refused due to personal time restraints posed by work demands. And given the initial history of symptoms before the development of leg pains, it was consistent with PMR, like the crowd discussed, and other secondary causes of large vessel vasculitis were excluded. And a clinical diagnosis of large vessel giant cell arteritis was made. Following a negative immunosuppression screen, the patient was commenced on high-dose prednisolone and a 12-month course of weekly tocilizumab injections with rapid resolution of symptoms and complete normalization of inflammatory markers. On follow-up, 1 year post-CA diagnosis, the patient remains in clinical remission with no further relapse and flares of his condition.
Awesome. This was a great case. I really enjoyed. I don't think about PMR often, but it was great to really go through all the different causes of proximal muscle weakness. So we entertained a large variety of different things and started dissecting and honing in on one possibility or two possibilities here. So I really appreciate the input from the crowd. So we all were able to get to the diagnosis. Any reflection? I heard David and Yasmin were giving quite a bit of input. Dani as well. Any reflection about this case before we do the teaching points? No worries. If not, we'll proceed on to the teaching points. Is it Ariel doing teaching points today? David, yeah, go ahead, David.
Yeah, I just wondered if I think the case pointed to PMR, but I don't think in this case I would have done a temporal biopsy, or at least if the echo is not doesn't have the typical imaging, or I don't know if another imaging test was performed, but would you have done in this case a temporal biopsy? What was the thing, or the clue that took you to do that test?
So what I do know is it just also pulled up 50% of patients with GCA have PMR, and those with PMR, 5 to 30% can have GCA. So if you have clinical manifestations in this patient, Rafa, I didn't see the manifestations of GCA, but were they there? Did I miss them?
No, this patient was actually diagnosed with extracranial giant cell arteritis, and it seems like in this case, these patients are mostly devoid of cranial symptoms, including the tenderness on the temporal arteries.
And what makes that diagnosis of extracranial GCA?
Okay, so the teaching pearl here is that contrary to classic GCA, extracranial tends to be non-specific and often devoid of cranial symptoms. And in fact, only 39% of the case supports that ACR criteria for GCA. And in some cases, solitary presentation of constitutional symptoms, severe fatigue might be the only complaint. Nonetheless, there are some important features that may increase clinical suspicion of this condition. A prior history of PMR is more common in extracranial compared to cranial GCA, and PMR with typical features of predominant lower limb pain, predominant lower back pain, refractory to moderately dose steroids, or severe systemic symptoms should alert clinical suspicion of extracranial GCA.
Oh, thank you for reminding us about that. David, did that answer your question? All right, should we go on to the teaching points, Ariel? Thanks.
Sure, I was struggling a little bit. So let's see, the patient presented with fatigue, weight loss, and joint pain. And we briefly discussed a little bit about fatigue and weight loss because they're quite non-specific, but we can approach that from an energy imbalance standpoint, either from a decreased intake or from an access loss. And we think about mnemonic there. And then we focus on the joint pain, and we raise a lot of good points. First, we want to know whether the joint pain is in the one joint or multiple joints. Is it in the joint or is it periarticular? Sorry, give me one second. And then we learned that the joint pain is symmetric and proximal in distribution, and that zeroes in two major differentials, including polymyositis and PMR. We talked about PMR could be from an autoimmune source like GCA, or it could be statin induced, which is pretty common, but this patient is not on this medication. And there could be some paraneoplastic syndrome presenting with PMR-like symptoms. In those cases, we think about upper GI carcinoma. We also talked about some patterns associated with these diseases. Is there any loss of muscle functions? Is it more pain or more muscle weakness? Any skin lesions, spinal involvement? And then is it worsen symptom in the morning, which is compatible with PMR? And then Rafa threw us a curveball, misleading us into thinking some endocrine diseases. So theoretically, hypothyroidism, Addison's disease, or Cushing's could lead to fatigue and muscle pain, but we also think that there are other pretty obvious physical examination abnormalities and blood work findings that we can't miss here. And then I sort of lost track. The patient is diagnosed with extracranial GCA leading to PMR presentation. I will update the whiteboard a little bit more. I just don't know enough about the disease, so little lost.
Oh, thank you, Ariel. That was great. I'll get off and help you with the teaching points as well. So no worries there. Thanks for volunteering, and thanks, Yasmin, for scribing today. Thanks, Rafa, for the case. Take care, everybody. Have a great rest of your Tuesday. See you tomorrow.